Okay. Good afternoon, everyone. Thank you, Dr. Sri Krishna and Dr. Sabrish, for facilitating this session. I am Dr. Anil, microbiologist. No, no, you haven't seen, must have heard about me. Well, I've heard on the phone. You must have called for reports. So, I'm a microbiologist, and we are doing a ICMR study on melioidosis. You know about melioidosis? You have an idea about melioidosis? So, it's a rare disease. It's rarely diagnosed, but it's a very dangerous disease. So, we'll be discussing that. And the, the the objective of today's class would be to sensitize you on melioidosis, to know what melioidosis is, what's the risk factor, what is the diagnostic challenges that we face, and treatment. Treatment is very important because treatment depends on the name of the organism, so we have to get it right and describe what ICMR per se is doing for melioidosis through this study that we are doing here in Amrita. So these are all the subheadings we will cover: epidemiology, clinical presentation, diagnostics, treatment, prevention, and ICMR. So background, so this is a heat map of melioidosis all around the world, and the red areas that you see, that is south of the world, that is where the melioidosis is endemic, highly endemic. The red areas are known to be very, very endemic. Anybody coming in that area, if he has melioidosis, you don't have any doubt about it. But somebody who is getting melioidosis in US or Russia or China may have to think that he must have gone to an endemic place and coming. So, but Southeast Asia is known to be very endemic. Australia is very endemic. India, South, we have a lot of cases. Per se, Indian subcontinent is very endemic to melioidosis along with Brazil. Africa, we don't have any data. You don't think that Africa it's not there, but data is not available. So this is the modes of transmission. It's a soil pathogen. It's in the soil, water. It's there in the environment. It's there in the Kerala environment, our soil also. So what happens is when you come into contact with soil and water, it could be either inoculation, that is a open wound which gets infected. Inhalation, that is the most common method. Inhalation, pneumonia is the most common method. And ingestion. Ingestion, that is drinking unchlorinated or unboiled water, may lead to infection. So in endemic areas, if you are going for a dip in the pond, it's dangerous. So that's the implication. So this is the pathogenesis. You have inhalation, you have ingestion, you have inoculation. Everything will go into the system and lead to a bacteremia. Bacteremia may be florid or maybe subclinical. So this bacteremia will seed the bacteria into different organs. This bacteria is very notorious, very pathogenic. So it will seed in different organs and it forms abscess in different organs. So it would be any organ, and pseudomegaly is notorious to infect any organ in the body. So it will form multiple abscesses. So patient may recover from the bacteremia and may develop an abscess somewhere. So he will present as a primary case of an abscess, a deep-seated abscess. So that would be one of the presentations of melioidosis. So it's Burkholderia pseudomegaly. It's a high-risk group 3 pathogen. It's a bioterrorism weapon grade pathogen. So if you're working on melioidosis and you publish on melioidosis, you won't get a visa for US because they will come to know that you are working on a bioweapon pathogen. Then the visa gets approved in the US headquarters. It won't get approved here. Believe me, it's true. So don't report publish any case of melioidosis if you want to go to US. But they will ultimately approve it, but it's a red flag that you have worked in a bioweapon grade pathogen. I will never get a visa, most likely. So this is the distribution epidemiology in India. You see, down south it is more because we report more. It's not that we have more, we report more. So Manipal, Karnataka, known to be hotbed because they have pioneered diagnosis. They were doing it since long. Kerala has got good diagnostic facility and many people go to Manipal for treatment. That's how some people get diagnosed. So we also have good number of cases. Tamil Nadu has got. Upper you go north, people haven't reported much, but this study, the 16 centers we have as part of ICMR study, we have AIIMS Bhopal, AIIMS Jodhpur, we have Northeast states, we have AIIMS Bhubaneswar. So wherever the AIIMS have come in, they have a lot of melioidosis because they have started diagnosing, because the infrastructure is very good. We have good clinicians, good microbiologists. So that's what is happening. So gradually the picture will change. Bhubaneswar, it's rampant. Orissa, it is very rampant, more than Kerala. So plenty of cases in Orissa. So they have started reporting now. So this is our, okay, this is a slide show. it won't come. No? So this is our publication. This is from the Department of Medicine and Microbiology. We published in 2021. Yeah. So 72 cases in 10 years, a retrospective review of 72 cases, 10 years means 7 cases per year that we were diagnosing, and total of 140 cases have been reported from Kerala, 140, highest from Amrita, 72, remaining case reports, because publishing case reports is very difficult, so we don't get much documented. So there are many cases which have been diagnosed and not published. So this is something that's happened last year, September. Kannur, there was an outbreak. There were 2 consecutive cases. Then we found 1 more case. And ultimately, the last case was a 1-year-old child that came to Amrita for treatment for pneumonia after going to multiple hospitals in and around Kannur. So child came with severe pneumonia after 1 month of pneumonia. And our pediatric pulmonologist did a BAL, and we grew pseudomyeli from the BAL, and we treated the child here itself for 1 month and then sent him home. The child recovered. So that was the 3rd case, or 4th case from Kannur, and the area is Payanur. And we thought of it because the location was Payanur. Payanur at that time was endemic and reporting many cases. So we reported to the government also. So risk factors, the biggest risk factor is diabetes, and we are capital of diabetes. So any diabetic who comes with a community acquired pneumonia, sepsis, or deep-seated abscess, think about melioidosis. Give it a thought, keep it as a DD. So diabetes is the biggest risk factor, followed by everything that Kerala has: chronic alcohol disease, alcohol consumption, renal disease, malignancy. Any reason for immunosuppression can lead to melioidosis. So gradually more and more people are on immunosuppression because life expectancy increases with chemotherapy treatment, and even biologicals. People give biologicals a lot nowadays, so you never know. Biologicals can also be a predisposing factor for melioidosis. The risk factors per se in Kerala, you don't need any risk factor because we are endemic. The area is endemic, and so you being in this particular area is a risk factor. But if you have diabetes, immunosuppression, more likely the patient will get an infection. So going to an endemic area would be a risk factor, but that doesn't count here. Then getting exposed to the soil, doing things that involve soil, that is gardening, farming, recreational work also. Yeah, as a hobby you are doing gardening or something, or maintenance work. Severe weather events, very common in Kerala. Floods, very common in the Kerala. Cyclones, very common in Kerala. So all these things will lead to aerosolization, and you inhale the. So the first case of melioidosis would be during the first rains. When the first rains comes in, that time you find a bout of melioidosis coming in. And then injury involving soil. The soil which is contaminated, water which is contaminated, or drinking unchlorinated water in an area which is endemic. So that's also one of the reasons. So this is why it happens. During the dry season, you don't find that much melioidosis, acute melioidosis, because the bacteria is below 25 to 40 centimeters. It needs a moist environment. So upper surface is dry, the bacteria is not surviving there. But as the rain comes in, the bacteria comes up into the soil because of the moisture. It multiplies, comes up, and you have the surface water contaminated with bacteria. And due to the windy season, rain, heavy rain and winds, aerosols are produced, animals get infected, humans get infected. So it is inhalation predominantly, pneumonia. The child that came to us was 1 year old, less than 1 year. He celebrated his birthday here, admission, completed 1 year. So they were wondering why a child who cannot even walk should get melioidosis. So most likely it is pneumonia that has aerosolized water that he inhaled that resulted in the. So this is a case of melioidosis who went into ECMO. This is a Hyderabad-born techie from California, went to Vietnam for vacation, and when he was coming back to India, on the way he stopped at Kolkata airport where he developed severe pneumonia and he was admitted in Apollo hospital, and then they diagnosed melioidosis. He was in ECMO for 1 month and then he recovered. So anybody going to Southeast Asian countries, Thailand, Vietnam, and coming back with acute pneumonia, think of melioidosis. That is a risk factor. Clinical presentation. Now it's a mimicker. Actually, it can mimic anything. Anything. Pneumonia is very common in your setup. In ER, you see pneumonia day in and day out. So it mimics anything. Most commonly, tuberculosis is a very big mimicker if you have a deep-seated abscess. The last case that we saw was a pot spine. It was being treated as pot spine for 4 months. And then she came here from Kasargod, and then we drained the pus and we grew pseudomyeli. So it was never a pot spine. The unfortunate part is that ATT doesn't work on pseudomyeli, so they will never respond to it. If you have brucella, brucella will respond. So you never know whether you treated brucella or treatment, but they will respond. So it could be acute, it could be chronic or reactivation, it could be localized or disseminated. So right now, one of you, Damodar named patient, you have admitted through the ER and it's going to the respiratory medicine. The blood collection was done in ER and it grew pseudomyeli. So we have a case of pseudomyeli right now, a diabetic septic patient in respiratory medicine being treated, but he is 96 years old, diabetic. So clinical presentation, it could be acute, chronic or reactivation. Most of them are acute, 88% of them are acute, only 9% are chronic and 3% are reactivation. So this is a clinical presentation. As I said, it can infect any part of the body, anywhere. But most common presentation is abscess. It could be brain abscess, liver, lung, subcutaneous muscle abscess. It could be prostatic abscess. Males prostatic deep-seated abscess, diabetic prostatic abscess, and parotid abscess. Children parotid abscess, Thailand is plenty reported. So we've seen cases of parotid abscess also. So any unusual place you see an abscess, deep-seated abscess, it could be. Children per se doesn't have any risk factor. Children are not diabetic, not CRR, not alcoholic, nothing, but still they have. So you don't require a risk factor for children to get melioidosis. So it could affect any of these organs and produce lesions. So you should always be aware that lymphadenopathy is one of the, so TB lymphadenopathy, you think it's TB lymphadenopathy, but it could be melioidosis. So we have seen lymph nodes also plenty which grow. So no classical symptoms. There is no hallmark signs or presentations of melioidosis. It presents like any disease, depending on which the site which is involved. You will have brain abscess. We've seen. They come here with brain abscess being treated as TB. We drained, we identified, but they went to a different hospital. And it's very fatal by the time the brain abscess is there. The patient died, invariably died. So this is the largest study on melioidosis. The most number of studies are done in Australia. Australia, Darwin Hospital. That's a publication from Darwin, Royal Darwin Hospital. 1,148 patients. 12% died. Mortality was 12%. Median age was 50. 4% were children. Children means less than 15 years, no risk factors, but still they get it. And 50% had more than 50 years. Were more than 50 years. 63% were male. 52% were indigenous Australians. 16% had no risk factors, but still melioidosis. 45% were diabetes, 40% were alcohol. So we have both these risk factors in Kerala. So we are a hotbed for melioidosis. The environment is also having pseudomyeli. 80% of the infections occur during the wet season. So during the rainy season only you've seen these acute cases, but during other seasons you will find these chronic ones, deep-seated abscess. In rainy season, expect pneumonia, sepsis. In other seasons, expect a deep-seated abscess. So that particular study showed that 52% were pneumonia. So most common presentation of melioidosis is pneumonia that you see in your daily basis in your ER. But if you have an acute pneumonia in a patient which is diabetic, think of melioidosis. Then you have skin soft tissue infection, 13%. Most often the skin soft tissue infection is, primary infection is chronic wound. Anybody presenting with chronic wound can be melioidosis. We have seen foot ulcers, diabetic foot ulcers. We diagnosed one case of diabetic foot ulcer. And wound ulcers are most commonly seen in children, chronic wound infection. Then you have genitourinary, 12%, and predominantly it is prostatic abscess. So you have a male diabetic with a prostatic abscess, think of melioidosis, because a routine infection needs treatment only 14 days, at the most 20-21 days. But melioidosis is not like that. You need a long-term treatment. We'll come to the treatment aspects. So sepsis was there without any secondary focus in 11% of cases. So the patient who came now had pneumonia and then sepsis. So he had a secondary sepsis, which is secondary to the pneumonia. Some people may not have a primary lesion and they may have sepsis. So soft tissue abscess, any person with a deep-seated abscess who is diabetic, CRF, think of melioidosis. It could be lung, it could be liver, it could be lung, it could be spleen. Brain, we have seen brain abscesses. Though the numbers are only 2%, it can present as cerebral abscess, meningitis, epidural abscess. Epidural abscess also we treated one. We treated brain abscess also one. Then you have osteomyelitis, that also we have seen osteomyelitis. In diabetic septic arthritis, think of melioidosis, send a culture. So, but the numbers are low, but still it is also a classical presentation of melioidosis, septic arthritis. This is our 10-year-old retrospective study, 73 culture proven cases, all culture proven cases. Most common diabetes mellitus risk factor. Pulmonary involvement was in 41%, abscesses were seen in 24%, lymph nodes were 13%, arthritis 12%, genitourinary 5%. Blood cultures were positive in 54%. You all send blood cultures. We have a very good system, a very good way of doing blood cultures. So we pick up a lot of blood culture positive in our primary cases where you send blood cultures by default. So we found 54% had blood culture positive. Our mortality was high, 20%. Darwin said it was 12%, ours is 20%. Chronic kidney disease and low albumin was considered to be a risk factor for mortality in our study. This is our 72 cases distribution according to the district. It's skewed because Ernakulam only caters to the nearby areas. So you won't go to the north or the south, it won't come. So most common people were from Thrissur. Right now the patient who's admitted is Thrissur. So he came from Thrissur. So most of the cases that we saw was from Thrissur. This is a publication that we did, Burkholderia pseudomallei in siblings, 2 children, and this sibling came to your ER only and died. I don't think, if you remember, the child died in a single day. The child presented with acute pneumonia and sepsis, and they sent everything, blood culture, even multiplex PCR was also sent. The PCR came positive, Burkholderia pseudomallei. Cultures came positive 2 days later, but child day, July 1, July 2 died in the year itself. And 1 month later, his sibling comes. August 8, he comes back with the same presentation, and we were aware that we were counseled that you may also have it. So we aggressively treated. We grew pseudomallei again from him, treated him, and he survived. So 2 children from the same family, one died with melioidosis. Then we did a epidemiological survey, and we checked his environment. Ourselves and Manipal supported us. Manipal brought the team, and we found 20 different sites we sampled. 3 sites were culture positive, 18 sites were PCR positive for melioidosis. So his flower pots, his water bodies around the house, everything had pseudomallei. So the whole environment is having pseudomallei. That's why these 2 children got melioidosis. It's rainy just at the onset of the monsoon, and we published it, and we counseled the family about precautions. So which is the most common presentation? Which is the most common presentation? Huh? Cutaneous lesions, abscess, genitourinary, pneumonia, all of the above. Which one? Which one is the most common? We inhale. Pneumonia is the most common. Okay, because that is the easiest way to get it. Ingestion, etc., is difficult. Pneumonia is the most common way of getting. So acute pneumonia in your presentation in a diabetic patient, think of melioidosis. So pneumonia is the most common presentation. Diagnostic criteria. Now you have to do imaging that you know better than me. You can do CT, you can do MRI, you can do X-ray, anything what you want depending on the site of lesion. Any lesion, anywhere, take the sample. It could be a deep-seated abscess, take and aspirate. It could be a sterile body fluid, it could be anything, any sterile body fluid, synovial fluid, pericardial fluid, peritoneal fluids, and biopsy or pus. Don't send swabs, send tissue or send aspirate. Pus swabs will not yield better. So send a sample, send as many samples as possible. Cultures may not come positive. If culture doesn't come positive, you have strong suspicion, send one more sample, again send it. And tell the lab that you are suspecting pseudomallei. We'll also put extra effort from our side to pick it up. Then if you tell us pneumonia is the most common, you send your respiratory sample, write query melioidosis on the request form. We will use selective media so that yield is better. Studies have shown that if we use selective media, because the respiratory flora has got, invariably E. coli Klebsiella will be there. So I don't want that. You want pseudomallei, I want to look at pseudomallei. So I will use a selective media if you tell me. So just write query melioidosis because you think he is having community acquired pneumonia, he is a diabetic or a CRF patient. Just write one line. We will do the needful because we have the capacity to use a selective media. We will put it and try to get a pseudomelie diagnosis, because otherwise it will not grow. And another problem is that the systems that we use in the microbiology can misidentify pseudomelie as Cepacia, Pseudomonas. Many patients have landed in your ER saying that they had Pseudomonas infection, but when we grew it, we found it pseudomelie. So many people get misdiagnosed as Pseudomonas. So that you should remember. Any patient with risk factors like CRF, diabetes, with a Pseudomonas infection, think twice, it could be pseudomelie. Just ask the lab, do you think it's really Pseudomonas or it's a pseudomelie? Because we had a case where a lymph node was aspirated from diabetic patient from endocrinology, Dr. Praveen's patient, and we gave Burkholderia cepacia from my lab. We gave it. That's long back, 5-6 years ago. He called me and asked me, Anil, this is a diabetic height and she is having a cervical lymph node and you are giving me Burkholderia cepacia. Then I said, wait, let me confirm. And when we went back and saw the cultures, it was pseudomelie, not cepacia. So you should also take initiative that any unusual site and we are giving a non-fermenting bacteria like Pseudomonas, cepacia, and you have a risk factor in the patient, call the lab and ask whether it's not a pseudomelie, just to rule it out, because treatment changes a lot. These PCR and hemagglutination are not available. Only thing that is available is culture. Culture is the only way diagnosing pseudomelie, to send as many cultures as possible, but also tell us that you are suspecting pseudomelie, so we can also put extra effort. So, which of the following pseudomelie is misidentified as A, B, C, or both A, B? Cepacia and Thailandensis. Burkholderia thailandensis is a non-pathogenic pseudomelie, non-pathogenic Burkholderia, which is not pathogenic. So, it's A and B, it can be misidentified, but Cepacia, you always think that Cepacia can be misidentified, pseudomelie can be misidentified as Cepacia in your patient with risk factors. Treatment, you have to be aware that pseudomelie is inherently resistant to penicillin, ampicillin, aminoglycosides, so you can't use your first line antibiotics that you use commonly if you are gram negative. So, it has got a very peculiar sensitivity, cotrimoxazole. Who uses cotrimoxazole? Ceftazidime, meropenem, doxycycline, and amoxicillin if you want. These are the best drugs and very rarely they are resistant to it. So, it has a very peculiar susceptibility. So, knowing pseudomelie is very important, because appropriate treatment will only happen if you know the identity. So, it has got an acute and it's like TB. It presents like TB, it has treated like TB, but it is not ATT. That's only thing. So, you have an acute phase and an eradication phase. In the acute phase, you have to give IV antibiotics 2 to 4 weeks or 8 weeks depending on the severity. The IV antibiotics would be meropenem or ceftazidime or imipenem. Then sometimes you have to add cotrimoxazole along with it. If you find the patient is very sick, giving meropenem alone you are not satisfied, you can add cotrimoxazole along with it. Cotrimoxazole IV. Then eradication phase, if you have cotrimoxazole along with it, you stop the IV, cotrimoxazole continues, or if you don't have cotrimoxazole along with your IV, add cotrimoxazole the moment you finish your 2 weeks or 4 weeks of intensive phase. Minimum 2 weeks. Any Melioid, minimum 2 weeks. 2 weeks of IV imipenem, meropenem is a big deal, costly affair, but you have to give it. If you don't give it, the patient will fail therapy. So you have to hit it hard. Then you have 3 months or 6 months of eradication phase, continuation phase as you say in TB. So 3 to 6 months. So treatment totally changes. Pseudomonas is only 14 days of treatment. Burkholderia is 14 days of treatment, at the most 21 days. But this is 2 weeks of intensive and 3 months minimum of eradication phase. Okay. So this is the Darwin study new guideline that they say that if you have minor infections like skin abscess, only bacteremia, no secondary focus, pneumonia without lymphadenopathy, 2 weeks followed by 3 months. 2 weeks of intensive, 3 months of continuous. But you have really bad infections like osteomyelitis, arterial infection, that is mycotic aneurysm, CNS infection, 8 weeks of intensive therapy, 6 months of continuous therapy, 6 months of, but that 6 months is only cotrimoxazole. That is the best part you can give, provided the patient doesn't have renal failure. If the patient has renal failure, then you have a bad thing. Now this is the dose, 2 gram 6 hourly for ceftazidime, meropenem 1 gram 8 hourly, imipenem 1 gram 6 hourly, that is the dose. Cotrimoxazole is 1 DSBD, 1 DSBD for, that is 3 months or 6 months, whatever you want to give. And there is a post-exposure prophylaxis that usually occurs when in lab, when there is an exposure. Not in environment, you can't give post-exposure prophylaxis. But you have technically you should know that there is available. You can give cotrimoxazole as post. So what should be taken into consideration when you are treating melioidosis? Severity, organ system, resistant, duration of treatment. What? Which one? All of the above. Because all of them is important. Severity will decide you 2 weeks or 4 weeks or 6 weeks or 3 months or 6 months. Organ system also will decide. If it's a neuromyeliosis, you have to give for 8 weeks of intensive therapy. Resistant, you know that your normal antibiotics won't work. Duration of treatment, yes, 3 months of minimum of eradication phase is required. Prevention, you can counsel them saying that the environment is infected, so you should be preventing contamination with soil and water when you go out. Don't keep open wounds and go out, and don't when it's raining heavily and there is windy, don't go out. Inhalation is a risk factor for all people with risk factors, not for everyone. Risk factors: diabetic, CRF, alcoholic, and immunosuppression. You can use waterproof boots, gloves. Drinking water should always be boiled or chlorinated. This child, the father asked me, why did my child get? None of us have got. So I asked, where did you take the water from? He said he has a well. And all of us, there's a joint family, 2 houses, we use the same water. I said, when did you last chlorinate it? He never heard of the process of chlorination. He has never done it. So I said, you should chlorinate your water. That must be the reason, one of the reasons why the child got it. But you should chlorinate the water. Chlorination is a very good method for decontamination of water. So key message is that it is curable, but you have to treat appropriate, intensive, and eradication should be correct. Otherwise, it will relapse. The patient will come. Dr. Shabrish has got multiple patients in his follow-up. They have successfully treated it, cured, because the drug was correct, the duration was correct. So what is ICMR doing? We are doing a project. This is a CD alert on ICMR 2019. They declared melioidosis is risk, and this is a study where I am the PI, Dr. Deepu, Dr. Divya, Dr. Purnima are the co-PIs. We are doing a study for 3 years. 1 year is finished, and the objective of the study is to increase the capacity in diagnosing and treating, and this is one of the objectives, to make aware the clinicians that how to diagnose, how to treat melioidosis. And this is the second year we will be doing that. We will be going around the other hospitals also. These are the cases that we saw. This is the first pneumonia, that patient died. This is brain abscess, that patient died. That is a diabetic patient with osteomyelitis, treated successfully, recovered very well. This is the 1-year-old child that came with pneumonia, recovered very well. That is a multiple pneumonodula, that also recovered. That is a spot spine diagnosed with TB. Spot spine, and we identified as pseudomyelite, being treated now. She got at least 6 weeks of IV meropenem. She couldn't afford meropenem. So somehow we tried to get it and we treated her with meropenem. She is on now eradication phase. So these are the number of cases we recruited: 93 cases with risk factors and suspected infection. 6 we got, at least I think it's become 8 now, 7, 8, 2 more cases we have identified. So research question, this is something that we would like to look, whether the environment is contaminated, whether there is a zero prevalence of melioidosis in patients in Kerala, which is the hotspot. Right now, Kannur, Kasargod, Palakkad, Pathanamthitta are supposed to be the hotspot. Thrissur has gotten cases. One of the cases in Vaipin, here we went and dug up the whole house surrounding, but we didn't find any melioidosis in that. But still the patient is there. He never left that place, so it could be there. So summary, think of melioidosis when you have risk factors in your patient: chronic renal failure, diabetes, CLD, anything. Diabetes mainly. If community acquired pneumonia or deep seated abscess, send a sample, write query melioidosis and send it to us. We'll take care. So you are doing your job, we will also do our job. Try our best to find out whether this is the case. It may not be, it's not that, but we should not be missing in a single case of melioidosis, because it's a death sentence if the patient is missed. Okay. So if your patient comes from any Southeast Asian country with acute pneumonia, think of melioidosis. Rule out melioidosis, just write in the microbiology form, rule out melioidosis, no harm in overdiagnosing. We'll also try our best, we will not miss it. You find any non-fermenter gram-negative like Burkholderia cepacia being reported in your patients with risk factor, think about melioidosis. Send culture, repeated cultures, so that we get yield, because culture is the only way to diagnose melioidosis. Thank you. If you have any doubts, you can ask. Any doubts? See, you are the primary responders. You will be seeing the first cases. All the milioid cases went through you. You send the blood cultures. That way, by the time they reach their wards, we could diagnose it. So you are doing a very good job. But if you write query melioidosis, we may find more. And we have seen in blood, that is fine, but we can see in respiratory specimens. If you have pneumonia, diabetic patient, CRF patient, send the sputum, send the BAL if you are doing it, write query melioidosis so that we can put a selective media and get it. That's all. Any questions? Team is there always. You can always call us, and for any queries, we can help you. Thank you, Sabrish. Thank you everyone for coming.